honor and privilege to introduce Dr. Douglas Kondziolka, who is at NYU, who's going to talk with us about radiotherapy for treatment of vestibular schwannomas. So thank you for joining us. We really appreciate it.
Thank you, Dr. Slattery, Dr. House, and everybody. And it's a real pleasure to be with you. I really think of the House Institute as really the preeminent center in the world, really thinking about the problems that we'll discuss tonight and around the topic. And I've known many people at the House Institute for a long time, 25, 30 years or so. And I've, really have to thank Dr. Brackman, who is obviously a beloved individual at so many levels. And I got to know him personally when he came to the University of Pittsburgh when I was there many moons ago. And we had the opportunity to spend time together, and then to see an array of House Fellows who came for some education and training in how radiosurgery was being used, particularly at the CT angle. And in this talk, I really want to share with you some of the things that we've been working on regarding the field of radiosurgery. So, this is what we hope to have. Of course, we take a small tumor and we do some biologic manipulation to it, and of course that's with radiation at present, may be replaced by something else at some point. The tumor responds, and by a relatively short period of time, it's barely visible. I would call this the hope. Unfortunately, this is not the norm, but it's something that is sometimes seen. And one of the interesting elements of a biologic response is sometimes the variability of that response. There's been a huge amount of literature published over years looking at this question. What is the best thing to do for a patient with a vestibular schwannoma? And this 2013 article in the British Medical Journal was quite good at the time. And it went through a lot of the pertinent issues in and around choosing observation, resection, or radiosurgery. But I think a really fine effort that was published a number of months ago is this analysis that came out of the last vestibular schwannoma meeting at the Mayo Clinic held a couple of years ago, and where in this Delphi model, where a number of investigators addressed what they thought were the best answers based upon the best science to a whole array of questions in and around vestibular schwannoma care. And for my patients who are struggling to make decisions on how best to proceed, I often turn their attention to this article, and they can spend the time reading it and going through the issues as we see it. So, a number of years ago, this paper came out, which was probably 15 years ago now almost, and it raised the issue as why radiosurgery might have been the most commonly used treatment for patients with vestibular schwannomas. And I don't know if that's true. There's probably 2,500, maybe 3,000 patients a year who are diagnosed, and probably 1,000 get irradiated in some fashion, and 1,000 get resected in some fashion, and many are observed, of course. But I think it doesn't really matter. I think what matters is understanding the different elements of the science behind this fascinating tumor. And one of the things that really has struck me is our understanding of the natural growth rate of untreated tumors. And until a few years ago, when we started this study, I always thought in my own career, one of the things that I did not do was to track the outcomes meticulously on patients who were observed. And when I got to NYU, there was a large proportion of patients who were observed. And in this study, we took 212 of them, and we did volumetric measurements of their tumors. And this was a monumental task done by Dr. Nakamura, who came from Japan and spent a year with us to do this work. And it's interesting that a lot of the prior natural history data, as you know, was mostly on linear measurement information. And sometimes the definition of growth was a tumor that went from inside the canal to outside the canal. So, if it grew 4 millimeters, but it didn't leave the canal, it was considered stable. in certain series. And of course, from a growth perspective, that's just not correct. And if you look at this paper from the group in Denmark on intracanalicular tumors over a long interval up to 2004, where the conclusion that, quote, tumor growth occurred in only a minority of patients, we know that's not true. We know that a minority, less than 50% growing, is just not the case, particularly when you're doing detailed measurements. And of course, that's not to be critical. In the older era, the quality of high resolution imaging with 1 millimeter slice intervals was just not available. So here's some examples of volumetric measurements. Here's a 67-year-old man. He's got a small tumor, as you see. It measures half a cc in November 2016. And you can see it is bigger, not even a year later, but it's tripled in volume. That's 358% growth by volume per year. And even though from a measurement perspective, you might look at the linear measurement and say it's 4 or 5 millimeters bigger, it's triple in volume. And these volumetric changes, I really believe, are the reason why patients will have changes in hearing or other symptoms, even when the size difference may not seem to be so great. Here's another tumor that is clearly bigger over an 8-month interval, and that's almost 200% growth, so twice the volume in that time interval. Here's one that didn't grow over a long period of time. You can see the change is 0.1% per year. It's very stable at 107 months, showing really no growth in this patient. So if we plot all these individual growth rates of vestibular schwannomas, you can see that these two black lines were tumors that actually got smaller. There's a fast growing group, which is more than doubling per volume per year. A growing group, which is more than a 20% volume change up to 100% per year, and then a relatively stable group, and that was 30% of the series. So if you look at this group, about a third of the patients didn't change very much within an average of a 2-year period, and 70% did, of which half grew fast, more than doubling, and half grew slower at the typical rate. And overall, that's an average growth rate of 33% by volume per year. I can tell you, we just finished a study of doing this in skull-based meningiomas, and they grew at 25% by volume per year. And this is very much in line with the findings of this paper from Mayo, looking at volumetric growth rates of vestibular schwannomas, as mentioned, with a 70% having volumetric growth, which is exactly the number I just showed you from our study in this relatively short period of follow-up. So, I think that's what we should understand when we choose observation for a vestibular schwannoma. And the first question is, will it grow? And how fast might it grow? And these are some of the population-based volume data on that. And when my patients choose observation, it's not like, of course, they're choosing nothing. They're choosing to let the tumor do whatever it's going to do based upon its own biology and growth rate. So, of course, there's many questions regarding whether someone might do radiosurgery or resection for their vestibular schwannoma, and not only related to controlling the mass, but saving hearing, facial nerve symptoms. There's a paper that I reviewed this week on the topic of dry eye and taste from nervous intermediate function, of course, balance, and even the different radiosurgery devices that exist. And one of the big, quandaries out there, real problems, is the problem of auditory deafferentation or tinnitus. And it's always amazing to see what's out there on the web and the popular press. And brain surgeons can scream, "This is medically impossible," all they want. I mean, this is fascinating, and I really think we need to do more for our patients in trying to understand tinnitus and the problems that it can cause patients. So it's been a long time since I wrote this little article in the Acoustic Neuroma Association notes, and we know that, of course, this is a significant emotional problem, not just a neurologic and otologic problem. One of the things patients ask is, what's the cause of my tumor? And one of the things we were interested in about 10 years ago was the impact of cell phone use on vestibular schwannomas. And as you know, there was kind of a real interest in whether that correlated with the electromagnetic radiation of a cell phone and vestibular schwannomas. And we did a very detailed epidemiologic study with some real experts on how to do this, where we studied cell phone use and exposure. And the control group were the spine patients who came to the neurosurgical clinic who did not have a vestibular schwannoma. And what we found was that cell phone use did not correlate with the tumor, but that the frequency of dental x-rays in fact did. And that if patients were having dental x-rays at the usual fashion, of course, most of us who see the dentist regularly for checkups might get a dental x-ray one time a year, the odds ratio was double the rate for those that did not. And that's the only thing that we've ever found epidemiologically in our own studies correlating with that. On the other hand, it may be that the frequency of dental x-rays correlates with some other thing, like, for example, economic status or exposure to something else. But cell phone use over a 10-year period did not correlate with the vestibular schwannoma. So I mentioned that when we choose radiosurgery, we're really talking about smaller volume tumors, of course, not large volume tumors. I'll talk a little later on what is the upper size limit. But of course, we want to stop the growth. We hopefully like it to be smaller, which is seen in about 70%. We want to take the open surgical risks off the table, even though they're fairly low. We want to maintain cranial nerve function in all its domains. And we're not so good at improving patient symptoms, because most patients, if they've already lost their hearing, we're not going to improve that typically. So the influence of vestibular schwannoma tumor volume and growth on hearing loss is really an important topic. And of course, when we observe observation or radiosurgery, what is better when it comes to preservation of hearing? And that's really a hot topic now. And of course, there's never been a randomized trial comparing observation to radiosurgery or observation to resection, but there is some retrospective matched cohort data that looks at this to some degree. So here's a patient who chooses observation for his 8mm tumor, and within a relatively short period of time, the linear measurement goes up about 3mm, and here he starts with 92% speech discrimination on the left, and by the time he has a follow-up, it is now lost. Now, this is a natural course of loss, and if he had been radiated, for example, would we have saved his hearing? We probably would not have saved his hearing based upon the anatomy of this tumor and its location to the cochlea. Here's a tumor, for example, that's small and intracanalicular, and the patient, it was interesting, this tumor was actually missed on an original MRI scan and had no symptoms. And the patient comes back 5 years later because of some other symptoms, gets a new scan, and you can see 5 years of growth was, from a volumetric perspective, you could probably fit 20 of those little tumors into the size of this new one 5 years later, but hearing has been preserved. And of course, because the tumor growth dimension did not go laterally towards the fundus. Here's a patient who chooses observation with a small tumor, and it's interesting that it goes from 5mm a year later, measures 10mm, but hearing is fairly stable. He watches it further, it's up to 17mm. And at this point, it's a 7 times volumetric increase. He then has radiosurgery, and you can see the early response. Would he have been better served early for hearing? We think so, but of course the data is not completely clear on this. And as I mentioned, this study done 10 years ago now, looking at observation versus radiosurgery for intracanalicular tumors, provides some information on this topic. It's a little bit of a difficult paper to understand because they combined 2 negative outcomes. One was the tumor grew, and the other outcome was hearing went down. And that combination of negative outcomes was worse on the observation cohort than it was on the treated cohort, mostly because of stopping tumor growth, but also because when that happened, some of these patients had preservation of their hearing. There's some emerging evidence as well that if you're going to try to obtain hearing, preserve hearing, you better do it early when the audiogram is at its best and speech discrimination score is high. And retaining class 1 hearing is just better if done earlier, and earlier typically means when the hearing is better. I have to say that 20 years ago, we really thought that if the hearing was still reasonable, we could preserve it. And that is just not the case. It's not as good as someone with type 1A normal high level hearing with a speech discrimination score between 90 and 100. As I'll show you in pure audiogram, our own registry based audiograms later, if the hearing starts to go down, it starts to drop. And even within subclasses of excellent hearing, you know, a lower score correlates with more loss. So if someone really is interested in preserving hearing, they probably should be treated earlier. And yet, of course, they're hoping their tumor is not going to grow and they'll preserve it naturally. That's the dilemma here. So we have this registry that we use, and this is a point of care registry I helped develop a number of years ago. I have thousands of patients in it. Every patient's data is entered every day. And I have a student who essentially takes a year off and helps run this from year to year as they try to, you know, improve their candidacy for getting into residency programs. It's like a gift to us. And we collect all sorts of information on the technique, their indications, their audiograms, and their outcomes, as you can see here. And one of the things that we've seen, you know, with some of the data shown is that not only are we collecting information about hearing, we're collecting information on tinnitus scores and balance. And I've always been interested that not only does hearing commonly drop in patients who were observed, but in this study from the Acoustic Neuroma Association, in patients who were observed, they tended to have more tinnitus than those who were treated. And treated was either resection or radiosurgery. So if one is trying to avoid tinnitus, seems to be that treatment is a better choice. One of the things we've been very interested in is the imaging. I call this the imaging of hearing function, and not just the audiogram. And this is the T2 signal of a KISS sequence or a Fiesta sequence. And of course, you can see the tumor here and the cochlea beside it. And you can see that on the side without a tumor, the cochlea signal is very bright. And you can see that the cochlea signal beside the tumor is much darker. And this is a person with hearing loss. And I look at this and I see this is a sign of cochlear health. And you can see that the health is much better on the side without a tumor. This, on the lower image, here's another smaller tumor where the cochlea is just as bright beside this tumor as it is on the contralateral side with no tumor in a patient with preserved hearing. And here's a patient who has a tumor, and we've preserved their hearing, and we've also preserved their cochlear signal. And this is a tumor that we have not kept their hearing, and you can see the cochlear signal is dark. So this may be an imaging marker of the cochlea, of the health of the cochlea. And I often show this to my patients because once the cochlea starts to go dark, even if they've got reasonable hearing, that's a highly predictive factor for further hearing loss over time. So you can see that here's a tumor, the small tumor, here's the KISS sequence, and here's some volumetric regression of it, and with preservation of hearing, you know, at the 2-year mark. I often describe this as the tumor regressed the right way, whatever that means. So at some point, you know, I really think this might happen, that we might change the way we talk to patients and use our data. We might say, you know, you have a small tumor, you've got excellent hearing, observation leads to tumor growth and hearing loss in the majority over the next few years. Hearing can go down even without much growth, and you should be treated now when your function is best. But we're not there yet. We will get there when the multitude of reports from leading centers show this. And that's just not happening yet. It's going to probably take another 10 years to know that. So here's the ideal result in a 59-year-old. She's got a small tumor. She has excellent hearing. You can see the 6-month, it's losing contrast from the vascular response. Here's at a 1.5 years, it's barely visible. You can see the little remnant along the nerve. the cochlear signal is bright, the tumor is smaller, and the hearing is normal. This is the ultimate combination of outcomes in every domain that we would want to see. So, we also know that the outcomes for surgical resection of such tumors utilizing middle fossa approaches and other approaches have been also improving. And one of the other elements comparing radiosurgery to observation in this study from UCSF was that surgery is cost effective, and radiosurgery is more cost effective than observation, at least in this model. And one of the things about residual tumors and facial nerve outcomes after partial resection of vestibular schwannomas is that you look at this comment, indications and protocols are still evolving. And however, a drawback is that a malignant transformation, that this could lie between 1 in 1,000 and 303 in 200,000. I'm going to talk about malignant transformation a little bit later on. I've never seen it in my 30-year career, and the risk is extremely low. And it is so low, and I tell patients to not even consider it. It's just as I tell them, it's even lower than the risk of dying from open surgery. And I tell them not to think about that one either, because they are almost fluke types of things. So this was the first era of radiosurgery, and this article we published in the New England Journal in 1998 was, I think, accepted because we had 5 to 10 year outcomes of this emerging concept, and in both in the patient's perspective. And if one was always interested in what was going on biologically to this, and there's a combined vascular and direct cellular response that leads to loss of contrast and the vascular changes and a sort of obliteration of the tumor, managed by granulation tissue. And of course, that's scar, and scars contract. And this darkness typically gets filled in over time because scars have vascularity. And that's why the tumors go dark and then they turn white again. And one of the interesting things was that over time, especially with the longer term assessments, we were seeing that this process of regression just seemed to continue. We really thought initially it would stop around 5 or 6 years, but it just seemed to continue. And so here's a tumor at 6 months losing its vascularity. Now it's off the brainstem surface. Of course, back in the old days, people were really concerned about, well, this is knuckling into the peduncle. It's compressing the brainstem. This patient has minimal symptoms from that. The patient's got hearing loss and some disequilibrium, but is walking fine. And within a couple of years, it's off the brainstem surface. This is a 9-year scan, and that patient's now at 17 years with a similar appearance. Here's a 24-year-old scarred follow-up, and that's what some of the old follow-ups look like. You can see the tumor edge is not round anymore. This is the irregularity of scar. And you can see some of the change of a tumor 22 years later, 17 years later, 19 years later, 20 years later. As you can see, it's really fun to see some of these long-term follow-ups. This is an interesting patient who works for a company in pharmaceuticals, and he's a talented guy. And he understands 3D printing. So every time he would come into the office, he would print out a 3D copy of his vestibular schwannoma and show me what it actually looked like. And this is a graph that he sent me. This is when he was started with his diagnosis. It was observed, it grew, then he was treated, and you can see the regressed remnant that he put together. So I had him hold up his actual tumor by his ear, and I had him hold his tumor up by his scan. You can see the three-dimensional change of that tumor over time. Again, we're very interested in the three-dimensional changes, not just the linear measurements. Now, having said that, as part of the biologic response, some of these tumors can expand. And I always tell my patients that, if you injure your knee, tomorrow you expect your knee to be swollen and your knee's going to be bigger. And radiation is a slow injury. It's not a tomorrow type of injury. And if we take a picture of this 6 months or so down the road, we may see that it's a millimeter and a half larger in measurement than it was previously. And here's somebody who's a 29-year-old woman. This is an old case. The dose of 17 gray is quite high. Normally now we would use 12 and a half or so. But you can see this tumor at 2 years looks dramatically larger. And at that point, we were quite nervous, thinking, well, this looks like nodular growth. And if the patient's well, and so you have to be very patient with this, and you can see that over time, this just simply regresses. And the data is showing that one has to be really patient. This is a paper that just came out in the Journal of Neurosurgery with 19-year follow-up of this sizable tumor, as you see, that loses contrast with volumetric expansion and further effacement of the fourth ventricle. Certainly, if this patient had significant balance problems, we would recommend a resection, but this patient didn't, as noted in the case report, and subsequently regressed. And you can see that appearance similar to the ones I just showed you a few minutes ago, where the edges are irregular. And look at the volumetric change of that increase and then decrease. And of course, this is the patient's own differential immune system dealing with the inflammatory cascade of this type of tissue injury. And in some, they just regress right away, and some occasionally will expand. Well, this technique has evolved a lot, and I want to mention something about hearing to you today, mainly related to the effects on cochlear dose. And I have to tell you that we started to care about cochlear dose only when otologists were coming to our training courses and asking about the radiation sensitivity of the cochlea, which was really quite unknown. So in 2004, I started to measure it in every case that had hearing. And by 2009, I had about 80 patients who had good hearing, where we measured the cochlear dose and we published the findings on the importance of that. So again, there's our cochlea. And over time, we would plan these tumors. We wouldn't even think about the cochlea, and we would get lucky occasionally. So here you can see a 12-year follow-up with fairly good preservation of hearing. Here's a 41-year-old woman with some tumor regression with preservation of the audiograms, over that time frame. And occasionally we would have a tumor like this that you can see is partly cystic, and the speech discrimination score was 0 based upon how the audiogram looks at that frequency. And you can see the regression of the tumor, the cyst part completely gone. You can see the small remnant at 4 years, and that part of the audiogram is improved, and the speech discrimination score has improved. So improvement in hearing is uncommon, but sometimes it happens when the tumors regress, as I said, the right way. And it raises the issue of cystic tumors. And some people have said, and there's a little bit of stuff on the internet, that cystic tumors are trouble for radiosurgery. That's not right. Cystic tumors are the best for radiosurgery. The tumor is already degenerating on its own, and the work is largely done. So when we have a tumor like this, is an 87-year-old person who's got some facial numbness from trigeminal compression. Here's the dose, 11.5 gray. It's actually a little lower than I typically use. And you can see at radiosurgery, here's at 6 months, already the brainstem peduncle looks flatter. Here's at 14 months, cyst is gone. So when I see a cystic tumor, and this is not always the case, of course, nothing is always the case, but frequently there'll be a good volumetric regression. Here's another one with multi-cyst in an 83-year-old. What are you going to do with this? In a large progressively solid tumor, she might need a resection, but here's radiosurgery at 2 months, and then at 2 years, and you can see that these peripheral cysts have just kind of gone away. So when we started looking at the cochlear dose, and then published this series after 5 years of measuring it back in 2009, we took patients like this, and I have to say that before this, we would plan the tumor, and we wouldn't even be looking over here where the cochlea is. So we started to measure this in every patient. And of course, when there was some distance in the fundus, these were the patients who were better suited to hearing preservation than those who were not. And you can see that the mean dose here was 3 gray. And it turned out that 2 things were found. First of all, younger patients did better when it came to hearing preservation. And patients with a lower cochlear dose did better. Now here's a 70-year-old in a tumor that had enlarged. We kept her cochlear dose at the magic number 4.2, which was the cutoff in the series. And you can see the scan at 5.5 years, and with preservation of hearing still in that same patient at 5.5 years in a 70-year-old. So this is somebody that probably doesn't fit the criteria for what we would expect for hearing preservation, and yet we were able to do it. And that's where that number comes from. So lower doses just seem to do better than higher doses. Having said this, I think this is too simple. And I think that you can't just put age and cochlear dose into some formula and come up with hearing preservation. I think this is doesn't take into account several really important factors, which are how long the tumor has been there, the ultimate health of the cochlear nerve and the cochlea, the degree of ischemia of the cochlear nerve from compression by the tumor. These are all things we really cannot measure. So intracanalicular tumors, under 60, smaller dose, these are all the correlates of hearing preservation. So why wait for the tumor to get larger, as I mentioned earlier? Because we're hoping that the patient may never have to fit into this paradigm, of course. So here's another one, cochlea tumor, fairly close, but the mean cochlear dose is low at 2.5 gray. Here's one where it's high. It's 8.6. So this is clearly way above the 4 gray line. So in a case like this now, I would probably back off here. There's a few tricks we would do to keep this low while still treating that. But this is just simply not going to be an expectation of hearing preservation in a case like this. But in a case like this, where it doesn't completely fill the fundus and it's a larger volume, here's at 2.5 years, the patient still has a speech discrimination score of 96% with that volumetric regression. And of course, the question you would all have is, is this going to be maintained? Is that going to last at 5 years and 10 years? And the data overall says that this patient should expect further hearing loss over time. And I tell all my patients that it may look good for a while, but that you should expect, a hearing loss that will happen progressively over time. It could be sooner or later. We're going to do our best to keep it. And the nice thing now is that with other augmentation technologies, cochlear implants, et cetera, we do have some other alternatives for these patients should hearing loss occur. So, just to show you, in a plan like this, the brainstem dose is low, the tumor is well treated, and the cochlear dose is low. And these plans can be made. And you can see here, we're bending the dose towards the cochlea. It's a very steep fall off here, and less steep here where it's not so critical, but steep here. And that's really the way this is done in all of these types of patients. And so in doing something like this, here's a patient who was going to be operated on at Mass General a number of years ago. He's 49 years old, got excellent hearing, normal balance. And he's got a tumor, pushing almost 3 centimeters, at least in one dimension. And he came and I said to him, you don't have any symptoms that absolutely mandate the need for a resection other than it's a larger tumor. So he chose to have radiosurgery, and this was the 6-month scan. I have to say that he's now about 5 years out. His tumor has regressed, his face is normal, he has no trigeminal symptoms, but his hearing is poor now. And so this degree of preservation lasted for about 2 years and then was not maintained, after that. So what about age? One of the other critiques years ago was that, this has got to work for a long time, for many decades, and just was there enough long-term data? How would a young patient respond? And it turned out that younger patients did the best, because younger patients always do the best. They're more healthy, their nerves are healthier, their structures are healthier, and their outcomes are better. So in the absence of randomized trials, there's been a number of matched cohort studies comparing resection to radiosurgery for smaller and medium-sized tumors, typically under 2.5 centimeters in maximum diameter. And this was the study that we did, published in 2016 in the Journal of Neurosurgery. And it showed that tumor control rates were very similar between the two outcomes, that facial nerve preservation was better with radiosurgery than with resection, although it was also excellent with resection. It just is better with radiosurgery, and because the chance of a facial weakness is really less than 1%, but high in both groups. Hearing was better with radiosurgery in the early years of follow-up, But if you took this out to 5 years, the survival curves begin to converge, as I mentioned earlier. So the durability of hearing preservation did not seem to last in this series. And the degree of other complications, of course, some of them are unique to the surgical exposure, like CSF leak and so on. And these are some of the defining points. So in my mind, for a smaller tumor, there's no medical indication that mandates an absolute need for a resection, other than if the patient has the psychological need that they want it resected, of course, that's important, or perhaps if they've got disabling vertigo or imbalance. And it may be that sectioning the vestibular nerve helps them recover faster. That's not completely clear, but that may be one of the other reasons, somebody with really disabling vestibular problems. But these are the matched cohort studies. And as I mentioned, they kind of usually agree with each other in terms of the various outcomes that I mentioned. And they go back to 1995. Now, here's the data from our registry that I mentioned earlier. This is speech discrimination follow-up score versus mean cochlear dose. And we can query this. In fact, I often show my patients my live data on this. And you can see that these are people who came in with a speech discrimination score of 90 to 100. So this is high-level hearing. And you can see between 2 and 4 gray. I said 4 gray was that upper limit. And so most of them are within this range. And you can see this is a fairly random distribution, which is kind of telling us that cochlear doses, it can't be the whole story. And you can see across this chart that most of the people in follow-up are keeping their hearing up in the higher levels, but of course there is some loss, as you can see there. Now this is hearing versus tumor volume. And so patients with smaller tumors have a better cluster up here for hearing preservation, kind of arguing to treat the tumor when it's smaller. Now, this is the group of hearing of an SDS 50 to 90. So these are the people who come in with their hearing not so good. And you can see that we are not doing such a good job of preserving hearing in this group. There's almost a random distribution after that point. There's no more clustering at the top. They're just as good to be frequent to be as low as they are to be high in that group. Again, once the hearing starts to go down, it becomes more problematic. And this is the same thing for smaller volume tumors. This is more of a random distribution. So the better hearing preservation data is people with high level hearing and smaller tumors. So, when it comes to looking at the various issues, quality of life becomes so paramount, and there's been a number of great studies on this. Brad Welling at MGH, their group have looked at this. Of course, the Mayo group have looked at this using the PanQual set of domains. And you can see that, amongst the different scores, everybody is doing pretty well between resection, observation, and radiosurgery across these domains. And one of the things I think that's interesting, and I talk to my own patients a lot about this, is quality of life is significantly driven by symptoms of dizziness and tinnitus. And when they're spending so much time talking about hearing, I really focus on the fact that from the Acoustic Neuroma Association, the 4 big goals: stopping the tumor, number 1, preservation of facial function, preservation of balance, and hearing was almost 4th in how the patients graded the importance of these outcomes. A happy patient who comes to my office a few years down the road has a controlled or shrunken tumor, a normal face, excellent balance, and hearing is somewhat neither here nor there. Of course, we're working very hard to preserve their hearing and understand the different domains, particularly get a better grip on tinnitus deafferentation as well. But if you look at these types of domains compared to the observation group, across all of them, most of the time we're doing well with whatever we're doing. And it's an interesting thing, when we looked at our own data on quality of life for vestibular schwannoma patients, the data was fairly similar to the general population norms of people who don't have vestibular schwannomas. So that's good news for all of us who are doing any kind of vestibular schwannoma care. What about the longer term data? We published some of the 15 to 20-year follow-ups. Here's control rates at 10 to 15 years. Typically, they're in the mid 90% range. But what if it fails? So failure after radiosurgery is an interesting topic. There's been a lot discussed at meetings. Is that scarred remnant harder to remove? Are the arachnoid planes lost? Is cranial nerve preservation more difficult? There's been a number of studies on this topic, not a lot, however. And all you can do is gauge the surgeon's opinion on the, quote, difficulty of the resection. Here's one where it was the usual or difficult or very difficult. I don't think this is so important. It doesn't really matter to me how difficult it is. What matters is the facial nerve outcomes. And in our own center at NYU, the facial nerve outcomes in previously radiated tumors have been identical to fresh tumors. And I think that in skilled hands, like at your place, ours, Mayo, and some of the other leading centers, the resection of a previously radiated tumor, of course, can be challenging, but fortunately, typically goes well. Here's one of mine that showed nodular growth over a number of years, and 6 years later, I retreated this patient who is now about 78 years old at a lower dose, and it's really rare to ever see failure after a second radiosurgery. So this is a recent paper on this topic on 76 patients. It's a multi-center report, and it usually works. Of course, these are people who are willing to have the procedure. Usually they don't have very large tumors. They've gone from small to still small or medium size. And you can see the response to the second procedure has typically been quite good. What about fractionated radiation therapy concepts? This is from Thomas Jefferson's series. The results for hearing preservation using fractionated radiation have not been as good. There was a lot of talk 10, 15 years ago that this was this way to save hearing, and that radiosurgery in a single session was more injurious to the nerves. That's not been the case. And hearing preservation has been poorer, actually, in some of the fractionated series than in the single session precise gamma knife style radiosurgery techniques. So, here's a patient of mine, and he's a recent guy that he has seen almost everybody, including probably people at your facility. It's been all over the country. We all know, we all have taken care of many people like this who's had many opinions. He is an engineer, well-read, and he started off with this tumor, and he watched it every year, and every year it got bigger. And eventually, I would just tell him, your tumor's a bit bigger. We're happy to help whenever you're ready to do something. So after that point, he said, I'm now ready. And he wanted a 3-session radiosurgery to, quote, preserve his hearing. Now, his hearing at this point, he had a word recognition score of about 25. And this was his audiogram. And but he still wanted to preserve the hearing in his ear. So we treated him with a 3-session, 6th grade times 3 approach, which is the biology that he desired. And you can see what the dose plan looks like for that. Is this the right thing to do? Is this a better thing to do? We don't know. And like everything we're doing, we track the outcomes. And this is done because over 3 days, he does not have a frame on his head. So the accuracy of this is not as with rigid fixation as a stereotatic frame. And so for a fellow interested in absolute, attempts at preserving hearing and the cochlea and so on, he was willing to submit to a less rigid fixation system. So he has a mask, and you can see this is a co-registered CT scan. You can see the cochlea here. And this is tracking, and this is a marker on his nose with a special camera array with the icon gamma knife. And you can see he's moving less than ½ millimeter through the course of his treatment as we watch him. He was a very reliable patient and has done well. So, what are the solutions to this problem? Well, it has to be accurate, conformal, effective, and with an understanding of the regional biology. And who should not have radiosurgery? Of course, patient choice, major imbalance from brainstem compression, intractable headache, intractable trigeminal neuralgia, hydrocephalus, or an unclear diagnosis. To me, these are all the reasons why somebody should not have radiosurgery. But here's neurosurgeons with vestibular schwannomas of different sizes and shapes. And here's a 71-year-old neurosurgeon from New York, as a matter of fact. And thankfully, his tumor shrunk and his ventricular effacement improved. So sometimes it's good to be a little lucky. Here's some other surgeons and their responses. This has been I'm sure you've obviously taken care of many physicians from across the world at your centers, and they're always a very thankful group to treat. As I mentioned earlier, what's the upper size limit for radiosurgery? This is a paper we wrote about 10 years ago for tumors above 3 centimeters in maximum dimension, but no bigger than 4 centimeters. And these were all patients who did not have disabling symptoms. And I showed this to Dr. Brackman a number of years ago, that by 2 years, 10% of these patients had come to a resection. And not because the tumor grew, but because they had persistent symptoms that just did not get better, that they hoped would. And they said, I want to try radiosurgery and I want to see if it helps. But, after a year of persistent imbalance or other things, they said, no, enough's enough, and I want a resection now. And that was that response. There's a number of other papers on the topic of Coos grade 4 tumors, and here's looking at volume evolutions, and you can see some increase before the decrease, but typically the response rate, as you see, over time. So one has to be, for a large tumor, has to be willing to be patient with something like this. And I treated somebody like this last week, and who has poor hearing, but normal face and no imbalance. And that was his goal, and we'll see how he does. So as I mentioned, there's a literature, and of course, if it's partly cystic, as I showed you earlier, these often regress, and you can see the response in that image. Now, the biology of these tumors, is interesting, and be interested in your thoughts on the really fast-growing ones. This is a young patient who was 30, had a resection of this tumor, and it regrew. Ki-67 was 5%. This was before the second resection, after only 3 years. And this was the post-op scan after, it was done at Bellevue here in New York, after that second resection. And then he was sent to me. And within a few months, 2 months later, it looked like this. And so we did radiosurgery on him in 2017. And this tumor has not grown further. It hasn't shrunk much, but in the last 3.5 years, it's been stable. And one of the observations made first by the Mayo group is that these faster growing tumors may not respond as well to radiosurgery as the slower growing ones. I don't know if this is true or not. We're tracking the information. It may be an argument to use a higher radiosurgery dose, however. So I mentioned earlier about the malignant transformation issue, and I mentioned that this is less than the rare risk of death following open surgery, so I counsel patients not to think about really either of these. But of course, there are case reports in the literature. Here's one from 2002. It's interesting that radiation gets a lot of attention in the popular press. And you may or may not know that low exposure to low-level radiation is one of the very few things that has been associated with increased longevity, for probably from clearing up any DNA issues one might have. This is an article from Mayo on a 25-year experience of radiation-induced tumors for benign disease, and they had no radiation-induced tumors. This is one arising from the 8th cranial nerve without prior irradiation after resection. This is our own paper published in Lancet Oncology with almost 5,000 patients with benign tumors with more than 5-year follow-up and no prior radiation. And the long-term risk, there was 2 cases, it was exactly the same as the general population risk. These were not tumors in the same area, but in the head. So the risk seems to be extremely low. And this is another one, late malignant transformation in the absence of irradiation. Of course, there's many things that can lead to this. This is a case from Carl Heilman at Tufts. He sent me, it's very interesting. Here's a vestibular schwannoma resected. Here's the 3-month scan doing well. I show you the temporal lobe here. And here's 5 months later, there's a glioblastoma in the temporal lobe right above where the tumor was. Just serendipity, of course. So in summary, we're continuing to learn about this fascinating tumor, about its biology, about its natural history, about what our techniques can and can't do, about avenues for further research. And it's clear that they really require dedicated teams, as we have at our institutions, utilizing high quality devices, high resolution imaging, paying close attention to the regional structures, and with a commitment to evaluation of all our results to improve our own outcomes. And thank you so much for your attention tonight.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.